This
Screen, but
conference
I
will
begin
now
here
be
with,
recorded.
okay. Good morning, all and everybody, respected teachers, seniors, and colleagues, and all my orthopedic batchmates. A very good morning and a happy Sunday morning and a bright day. Hope you all are keeping well, health and wealth wise. Okay, so once again, we are as a BOA with a wonderful CME. The topic is there a SCOPY, that is arthroscopy, beyond knee and shoulder? Yes. The topic is this, and yes. So from today, we start exploring those uncharted terrain under the guidance of experts from Baroda Orthopedic Association as well as national faculties. May I request Dr. Aditya to take over as a moderator? And Aditya is orthopedic surgeon, associate professor at SDKS Medical College, Piparia. Aditya, please take over.
Thank you, Dr. Alpesh Bhai. So today we'll discuss the different avenues beyond the knee and shoulder scopy, that is wrist scopy, ankle scopy, as well as the hip scopy. In our panel, we have eminent speakers. First, I introduce Dr. Manoj Mehta, sir. He is the medical director of Sai Sports Injury Center, Baroda. He is a pioneer for arthroscopic surgeries in Baroda. He has done his fellowship from UK, Italy, and South Korea. He is also a member of various international and national associations for SCOPY. The second is Dr. Milind Pimprikar, sir. He is the medical director of Pimprikar Orthopedic Hospital at Nasik. He has done his fellowship in joint replacement and sports medicine from Germany, UK. He is also a member of ISACOS as well as Indian Arthroscopy Society, Shoulder and Elbow Society of India, Indian Foot and Ankle Society. He has conducted various conferences, workshop, and fellowship training in arthroscopic surgeries in Maharashtra. He will be going to talk about ankle arthroscopy. Then we have Dr. Smit Matalia. He is the medical director of Dwarkesh Hospital, Baroda. He has done his fellowship from Kiel University, Germany. He has 17 years of clinical experience and special interest in knee and shoulder surgeries. Today's talk from him will be on ankle arthroscopy. Then we have Dr. Jaimeen Jesalpura. He is the medical director of Vaishnavi Orthopedic Hospital, Baroda. He was also the organizing secretary for Baroda Knee Arthroscopy course as well as Baroda Orthopedic Association. But unfortunately, today he will not be presenting because of some social and personal problems. So the talk on hip arthroscopy will be taken over by Dr. Prathmesh Jain. He is the medical director of Advanced Knee and Shoulder Hospital, Ahmedabad. He was a gold medalist from AIMS during his masters in orthopedic surgery. He has performed more than 1,000 arthroscopic procedures every year, and he is a US certified fellow in arthroscopy and sports medicine. Then we have the eminent speaker, Dr. Abhijeet Wahegaonkar. He is the adjunct professor of hand surgery, a distinguished clinical tutor of orthopedic surgery. He is the director of upper limb, hand and microsurgery fellowship program, and he is also the consultant and head of upper extremity hand and microvascular reconstructive surgery department at Sancheti Institute for Orthopedics and Rehabilitation. He has various publications in PubMed Index journals. He has written various chapters. He is also the founding president of Wrist Society of India and member of international and national associations. Then we have Dr. Pranav Patel. He has done his fellowship in arthroscopy and sports medicine under Dr. Milind Pimprikar, sir. And he has various presentations at national and international level, as well as publications of in various journals of repute. So we start our session with Dr. Pranav Patel, who will be talking about wrist setup and portals. Dr. Pranav Patel.
Yes. Yes, thank you, Dr. Aditya. I can share my screen, right? Yeah. I'm not able to share the screen, Kshitij. Hello, Kshitij.
Kshitij sir, please help him.
Hello. Can you see my screen? Aditya?
Not yet.
Not yet.
No, not yet.
No, I'm not able to share my screen.
Mr. Kshitij? Mr. Chirag?
Yes sir.
I'm not able to
Yeah,
share
Dr.
my
Pranav
screen.
Patel is not able to share the screen.
Okay.
Sir, I have already make you as a presenter.
Yeah, but the share screen logo is just loading and loading. It's not going forward or backwards.
1 minute sir. Kshitij
Okay,
sir, please help him.
I'm there. Dr. Aditya Agrawal.
Yeah, mine is
Currently,
done.
Dr.
Now
Pranav
please,
is the organizer.
yes.
Okay, who wants to share the screen? Dr. Aditya Agrawal?
Dr. Pranav Patel.
Okay, Dr.
Myself.
Pranav Patel, your screen is, you can start sharing your screen. No? There is a screen button that you can see.
No, that button is not working.
Just hold on. Okay, now can you do that, sir?
Now we are able, yeah, we are able to see. We are able to see the laptop screen.
Okay, Dr. Pranav,
Yeah.
can you share the screen now?
No, I'm not able to.
I think some, what is the issue that you're facing, sir?
That
Because I can see that you are an organizer,
button
but you have logged in from the web. Can you just download the application and log in again?
okay. Just a moment.
You are logged in from the web link.
Yeah, I've logged in.
You have to download the application, log in again.
Oh. Then I think we can start with the ankle first, and then we can come back to this.
Okay, who's going to do the
Smith,
ankle?
if
Yeah,
you are ready, then we can proceed. Smith,
yes.
Who is going to do the ankle?
Smith,
Dr. Smit Matalia.
Dr. Smith,
I'll make Dr. Smit Matalia as the presenter.
okay.
Smith,
Okay,
are you comfortable
Dr.
to
Smith,
share your screen?
yeah, Dr. Smith, you can start sharing your screen. In the meanwhile,
Yes.
Dr. Pranav, I request you
Yeah,
to come back again to
Smith,
the
we are
application.
able to see your screen. That's very nice.
Okay. Okay. So, should I start?
Yes,
I
sir.
think Smith, you can proceed. We are able to share your screen.
Good morning, everyone. Good morning, friends, colleagues, teachers, and senior faculties, and warm welcome to the faculties from the outside of Gujarat. And it's a nice Sunday morning, and we'll be talking on ankle arthroscopy today. So, my topic is about ankle arthroscopy setup and what are the portals that we use to go ahead with ankle arthroscopy. So, ankle arthroscopy is now one of the third most common joint after knee and shoulder arthroscopy to being arthroscoped, and gradually as it progresses, more and more ankle arthroscopies will be carried out, and as the sports injuries section is quite advancing rapidly, we would see a lot number of more ankle arthroscopies to be done. So one of the difference as far as the knee and shoulder arthroscopy is concerned, the main thing is that the scope that is we use for the knee and shoulder, comparatively we have to use a short barrel scope in case of an ankle arthroscopy, so that it becomes much more comfortable to maneuver in a tight joint, and the ankle is comparatively a smaller joint as compared to the knee and shoulder. So if you have a short barrel scope, then it's much more comfortable viewing all the areas and reaching to all the parts of the ankle joint. However, in the initial part of my practice, I continued doing ankle arthroscopies with the long barrel scope that we used to do in knee and shoulder, and I found it to be reasonably comfortable. So it's okay if you can start doing ankle arthroscopy with the long barrel scope also. However, short barrel scope is a preferred thing. Now, as far as the position of ankle arthroscopy is concerned, is generally a fine position with the leg dangling down the table like this, because ankle arthroscopy is one scopy in which you can have the access from all the three directions. Like you can have the from the medial side, from the lateral side, from the anterior aspect of the ankle scopy, and also you need to occasionally, in some case procedures, you need to have a portal from the posterior aspect. So in this particular position, it becomes much more comfortable to establish a posterior portal by rotating the leg from the hip, and also by elevating the ipsilateral hip or by tilting the table. So this is the preferred position in case of an ankle arthroscopy, and you cover the toes with a sterile gloves and isolate the ankle region. Ankle arthroscopy is generally carried out like this. Occasionally, some people do use such a type of stretching apparatus, because ankle joint is comparatively quite tight, and unless it's a lax ankle in case of an instability. Occasionally, in very rarely do we use an invasive traction apparatus like a Sinman pin inserted in the calcaneum. I have never used, or I've never seen such being used, and preferably my assistant generally gives the traction whenever it is required. So generally, the traction apparatus are generally not required. Generally, you can do it with the help of a manual traction. Now, as far as the surface landmarks is concerned, in order to establish the portal, we need to have the knowledge of the important anatomical landmarks, the surface landmarks, as well as the important structures that are traversing all around the ankle. So I would just come here. So this is the anterior ankle region, and if we come from the medial to the lateral direction, we can see that the malleoli are the most prominent parts of the ankle, and this is the first thing that we should palpate before proceeding to take the portals. So we have to palpate the medial malleolus, and the anterior ankle joint space is about 2 centimeters proximal to the tip of the medial malleolus, and in case of the tip of the lateral malleolus, the anterior ankle joint space is about 3 to 4 centimeters proximal to the tibular tip. So as we go from the medial side, there's a great saphenous vein along with the long saphenous nerve going just anterior to the medial malleolus, and then we have the medialis anterior tendon, then extensor hallucis longus, and the extensor digitorum longus. In between these is the anterior neurovascular bundles. Occasionally, it is helpful if before we proceed with the ankle arthroscopy, or we induce the patient either in the spinal or under general anesthesia, it's important to mark the landmarks or the location of such tendons with help of some pen, especially in the initial few cases, so that we know whether and we don't damage them while introducing a portals or while doing any procedures. So these are the important anterior structures. Now, as far as the posterior structures are concerned, in the posterior, in the central port, is the main tendo-Achilles tendon. And occasionally we establish the posterior portals is the posterolateral portal or the transtendinous portal through the tendo-Achilles. In case if you want to do some procedures in the posterior ankle joint space. As far as the posteromedial area is concerned, that is not considered to be suitable for any portals because of the presence of the neurovascular bundles, the posterior tibial artery and the nerve, and especially the flexor hallucis longus and all the flexor tendons. In case of the posterolateral region, we have got the peroneal tendons, and the posterolateral portal is carried out just at the lateral border of tendo-Achilles and between the flexor hallucis longus and the peroneal tendons. Especially when establishing the posterolateral portal, you can see here the sural nerve is going very close to the border of tendo-Achilles, which is at risk of getting damaged when establishing the posterolateral portal. You should be careful of the sural nerve when you're going for the posterolateral portals. And when the anterior region is concerned, we have the anteromedial portal and the anterolateral portal. Anterolateral portal is just lateral to the extensor digitorum longus, and the anteromedial portal is just medial to the tibialis anterior portal. And this is how we carry it out. So after doing a adequate amount of examination and palpating all the malleoli and the joint space, then we first use a freehand needle and introduce it into the ankle joint, and by as soon as we enter the joint, we can see that our needle is we are able to freely move the needle. Once we are sure of that, after that we distend the ankle joint with help of 5 to 10 ml of saline. As soon as we introduce about 10 to 10 ml of saline, 5 to 10 ml of saline in the ankle joint, we can see that the ankle joint is getting distended. And the most important sign that we see while doing this distension is the gradual dorsiflexion of the ankle happens as you distend the joint, which confirms that our needle is within the joint. There are two occasions when we find out quite of resistance when we introduce the saline fluid. One is that if the needle is outside the joint. If the needle is outside the joint, there will be more amount of resistance, and we'll see the subcutaneous location, the fluid is getting extravasated. The same when we try to introduce a vein fluid. The other possibility is when there is a lot of adhesions in within the ankle joint. At that time also, there would be a lot of resistance by introducing the needle in the ankle joint. So once we have introduced the saline within ankle joint and distend the joint, the next point will be to take an 11 number stab knife and just put an incision in the skin. Here we should be very careful so that we don't damage any underlying structures, and with help of a hemostat, we spread the forceps and try to reach the capsule of the ankle joint, and then with help of a blunt trocar, and we introduce inside the ankle joint. Here you can see that the difference between if you use the short barrel scope is much more easy to maneuver. In case of a long barrel scope, there is a considerable long lever arm, so it remains much more unstable situation as compared to a short barrel. But still, this is not this is possible clinically also, that you can do it with a long barrel scope also. The important thing here is to see that the ankle joint scope is the scope direction is going quite laterally. It is not vertically going down within the ankle joint. You have to enter the anterior ankle joint space. So this is the direction of the scope that is being we have to go. So once you put your scope inside the joint, you can see the anterior tibial margin is the first thing that we visualize, and the dome of the talus. And the posterolateral portal is generally the first portal to be established and considered to be the viewing portal, and the anteromedial is the instrument portal. And once we enter into the ankle joint, we use a needle and we pass just medial to the tibialis anterior tendon, and we palpate our joint space, and there we introduce the needle. Once we can see the needle, we push the hemostat artery forceps and then broad it, and then we introduce our probe inside. So once our probe is introduced, that is our finger in the joint, and we can palpate all the structures. We can see the dome of the talus, we can see the medial malleolus, the anterior tibial margin. Ankle joint is comparatively a more peculiar joint. The talus is such so that it is concave in the coronal plane and it's convex in the sagittal plane. And especially because of the presence of the elevated margins of the medial and the lateral talodome, which it is very difficult to scope in the inside of the joint. And for that, manual traction might need to be given. And occasionally, it is quite difficult to see the posterior aspect of the talar articular head. But fortunately, we can move the ankle and the foot and bring the posterior aspects of the talar head into our view. And occasionally, some lesions, if not able to reach out quite posterior, then we can establish a posterior portals. So these are generally the first view that we, as soon as we enter the joint, we can see here the medial gutter here, which is the occasional the place for the loose bodies and the synovitis. And the same way, if we introduce the joint, we can then put our switching stick and enter through the anteromedial portal and see towards the lateral aspect of the ankle. So here, when we want to introduce the see the posterior aspect of the talus, this is how we do. We go towards the lateral bud of tendo Achilles, and we keep our scope anteriorly, and we pass the needle through the lateral bud of tendo Achilles, protecting the sural. Now we can see this needle entering in between the tibial articular, distal tibial articular surface and the talodome. And after introducing the needle, we introduce our stab knife, and then we can put the switching stick and put the scope in the posterior portal and view the posterior ankle space like this. And this is how we can do, which is occasionally the space for the loose bodies. Occasionally we need to do a synovectomy in case of rheumatic ankle, or case of an infective ankle, we need to give a lavage or wash over there. So this is the posterior inferior tibiofibular ligament. Occasionally we can see, which is basically the thickening of the syndesmotic ligament, that is the inferior portion of the syndesmotic ligament. So I think that is all the structures that we generally see when we're doing an ankle arthroscopy, and there are two anterior ankle portals and one posterior portals, and the position that I have shown. I think the Milind sir will carry out more and tell you detail about the indications and the other type of ankle procedures. Thank you.
Thank you, Dr. Smit Matalia, sir, for excellent
Yes.
presentation on the basics of ankle arthroscopy. I request Dr. Milind Pimprikar, sir, to please proceed with the indications for ankle arthroscopy.
So, Chirag, Dr. Chirag, did you receive the presentation, and can you open that for me, please? So I'm not able to share my screen as yet. So I've sent my presentation to Dr. Chirag.
ओके सर, 1 मिनिट द्या, मी करतोय सर.
हो चालेल.
Mr. Chirag, I think this is okay. Dr. Milind, sir, you are comfortable with this?
Actually,
You will have to tilt your screen.
so no, that's fine. What I just want to know is, are the videos going to play here?
No, the videos won't play in this.
So there is no point presenting because there are a lot many videos there. What is the other option?
I think the PowerPoint can be downloaded from the Google Drive and then played. So I think it should be downloaded to the desktop or to the computer, and that would help play. If the file size is very large, I would suggest sending the file, resending the file using vSendIt. So that'll send the file directly as a PowerPoint, and that could be downloaded by the person to whom you send the files.
Yes. So I have actually sent it on a drive, and if you download it from a drive, it should play.
Yeah.
So
Yes.
can somebody do that? So it's on the Google Drive.
Have you shared the link as someone can edit or someone can download?
Yes.
Yeah, great. So
Yes.
and you sent it to whom, sir?
I sent it to Dr. Chirag.
Chirag. Yeah, Dr. Chirag, please download it from the Google Drive to your computer, and then you can play it as a PowerPoint.
Sir, we have taken, it is a 83 MB file.
Yeah. I think it's best to download it.
पिंपरीकर सर, कुठल्या स्लाइड वरती आपला व्हिडिओ आहे सर?
आपल्या सगळ्या स्लाइड्स वरती व्हिडिओ. There are going to be 7 or 8 cases of different kinds which I'm trying to show, so that it will cover almost all indications in anterior as well as posterior ankle scope. Meanwhile, can somebody try doing this screen share again? Because Pranav, if the next speaker is able to share it,
Yeah, one
can you
second,
go
I'll
ahead?
try.
Pranav,
So let's,
Pranav, are you
I,
ready?
we can,
And we
yeah,
can
I'm
proceed.
ready.
I think we can proceed with your.
Yeah, I'm not getting the option of share
Sir,
screen.
Dr. Pimprikar, sir, we are able to
Is
see
it
your
okay?
screen.
Yeah, Dr.
Yeah,
Pimprikar, we are able to
yes.
see
So,
better.
we are able to see the
पिंपरीकर
screen,
सर
no,
sir.
बिझीच
that's
आहे का
Proceed.
जरा एकदा चेक कराल.
no, this is not my screen. This must have been shared by
This is
Dr.
my
Chirag.
screen. This is my screen. Kshitij Bhosle.
Yeah. Okay,
Okay.
Kshitij. So,
हाँ.
so if now you will be able to control the presentation, I won't be able
Yes
to
sir.
do that.
Yeah, I will be able to control. तुम्हाला सांगायला लागेल सर नेक्स्ट स्लाइड म्हणून.
हा, तर नेक्स्ट स्लाइड करत करत एक व्हिडिओ प्ले होतोय का बघ ना.
सांगा सर कुठल्या ह्याच्यामध्ये आहे.
इफ इट इज प्लेइंग, हा जा ना पुढे जा अजून. Go. Yeah, keep going. Now see, can you? Yeah, go. Yeah, keep going. You'll have to keep going till you
Yes,
still
sir.
further. Yeah, still further. Yeah, still further. It starts with case number 1. So this is case number 1 now. Go ahead. Next. Next. Now try and play this.
नाही sir. I think when you had sent the presentation has come, but there is no video attached.
Okay.
व्हिडिओ आलेला नाहीये सर. सर एक काम करूया सर. I will try to make you share the screen once again.
Yeah,
Okay?
do that. Let's see.
Okay. Cool. Sir, on the right hand side of your screen, there will
Yeah.
be a screen button.
I have shared now.
Oh, perfect,
Now,
sir. I
able to
can see your
my
screen.
Great. Perfect.
We can see your screen.
Okay. Now
Go
can we
ahead, sir.
see the presentation as well?
Yeah, we can see, sir.
Wonderful. Great.
Sir,
Yeah.
काय केलं सर आम्हाला पण
now we
शिकवा
have
काय.
opened up, sir.
Yes, sir.
Sir,
Is
sir,
that
please
fine
proceed.
now? Yeah. Okay.
Yeah, sir. Yes, sir.
Go ahead, sir. You can start.
Right. Okay. So all that ends well as well. Thank you for the previous speaker for a wonderful presentation on how to do an ankle scope. So today's talk is going to be basically a case-based talk, which is going to tell us about the indications of ankle or role of ankle arthroscopy in orthopedics. It is a well-established role, and the indications of ankle arthroscopy have really expanded in last few years. So if you really classify indications, you can classify them into anterior ankle scope, that is anterior arthroscopy, posterior arthroscopy, which is also called as hindscopy, and we can also do certain tendoscopies where we scope the tendons, for example, in flexor FHL tendinopathies, peroneal tendinopathies, so on and so forth. For anterior ankle scope, the most common indications are seen in yellow, which are anterior impingement, osteochondral fragments or osteochondral disease, which is more than 15 millimeters, and ankle fusions. Ankle synovitis, loose body removal, arthroscopy assisted fracture fixations, ankle instability, septic arthritis, and osteoarthritis of the ankle are some of rest of the indications. If you consider a posterior ankle scope, we can classify them into the tissue which is affected. Like if you have bone, then you have a symptomatic impingement because of os trigonum, you have Haglund's deformity, biparietal talus, loose bodies, and ossicles. As far as cartilage is concerned, the commonest disorders which we face is OCDs and chondromatosis. And as far as soft tissues are concerned, they could be FHL tendinopathies, retrocalcaneal bursas, post-traumatic synovitis, and villonodular synovitis. Wright gave this paper where he had classified the indications and grading according to the effectiveness of the surgery. And if you see the evidence, he classified into A, B, C, and I, where if you see this table, then you have B grading only for first three conditions, which is impingements, osteochondral defects, and ankle arthrodesis. Now, if you see this B, which means there is a fair evidence, which is level 2 or level 3 studies confirmed for recommending this as an operative procedure. The rest of them, they still have a questionable value, and this was written by Wright way back in 2005. Portals we all have seen. So these are normally, you can see that it's a AL portal, this is low AL portal, you have AM portal and low AM portal. These are anterior portals which we use, and there could be another portal which is a central portal which can be used for anterior ankle scope, which has been dealt with by the previous speaker. These are the posterior portals where you have a transtendinous portal, and this is the viewing portal which is just para tendoachelis. So since it has been discussed, I will not go into the details of it. That is the tibialis anterior. That's the way how you push in a needle after marking the ankle. In anterior scopy, I tend to keep the ankle hanging outside the edge of the table so that you have a good control over the foot. Although I don't use a strap to distract the joint, your assistant holding the calcaneum and giving an anterior thrust is probably good enough to negotiate the scope in different areas of the ankle. So that's how the typical position looks like. And I do not use a short barrel scope, although it is advisable as quoted by the previous speaker. And it is really nice to have a short barrel scope to have ankle arthroscopy done. So these are a few indications which you can see. That's the Hageland's disease, and that's the Hageland's deformity, and that is os trigonum when you talk of posterior ankle scope. So taking this into consideration, I have classified the talk into certain cases so that we can have some common conditions dealt with in the form of case presentations. So case number 1 is a 39 years old female, came with the chief complaints of pain right ankle for the past 6 months. There was a history of trivial trauma, swelling at the end of the day, and unable to stand or walk for prolonged distances. Now, on examination, this lady had a full range of motion at the ankle. The dorsiflexion was terminally painful. There was anteromedial joint line tenderness. There was tenderness over the plantar fascia too, localized tenderness over the lateral joint line, but there was no instability and no DNVC. If you have a look at the X-rays here, the AP does not show much, but on the lateral X-ray, if you see that there is a huge, large, loose body which one can see there. There are certain osteophytes we can see here. Now, if you are dealing with anterior impingements or what is called as footballer's ankle, you would also see certain amount of osteophytosis at the anterior tibial margin and onto the talus, giving rise to a kissing kind of osteophyte scenario. And that's one of the good indications to undertake anterior ankle scope. So this X-ray looking at this huge loose body, we thought that there has to be a OCD associated with this as well. And that is why we got the MRI of this patient done. Now, if you have a look at serial MRIs, you can see a loose body which is lying there. And if you have a look at this MRI, you can see an osteochondral lesion onto the talus, onto the anteromedial aspect. So that's the MRI picture. And this patient was then posted for anterior ankle scope for removal of loose body and to have a look at what is happening to the ankle. Now, additional permission required to access following files. Just a second. Now, there's something is okay. So grant access, right? So that's the video. So that is the ankle, as it has been very nicely stated by the previous speaker. That is the anterior inferior tibial margin. That's the way how your needle comes in, and this comes in at the base place, which is followed by a 11 number blade, and then the probe comes in. These are all knee instruments which have been used, and you can see there is a huge defect onto the distal tibia there. That's a defect onto the talus as well, and that is a loose body. So with a knee grasper, we catch hold of the loose body, and the loose body is removed. Now, if you see here, the talar dome has undergone degeneration, as well as there is degeneration onto the distal tibia. In such situation, what literature states is near debridement of the defect with whatever like a shaver, a radio frequency, and a curette to take out the loose pieces of the cartilage is the treatment which is treatment of choice. Now, in this situation, any instrument which becomes handy should be used. I use a lot of small osteotome to remove the osteophytes instead of burying them, because it is a one-stroke treatment and it saves on time. Because if you're burying it, then it takes a lot of time and it is sometimes difficult to maneuver that. So in this, using all the equipments, the debridement was done. Even a burr was used to smoothen the edges of the distal tibia, and a contour pick was used to make microfractures. So microfracture has shown to be a very good method to deal with such OCDs which are smaller and which are not full thickness, or in degenerate ankles or degenerate pathology like this, where you can see that no osteochondral graft is going to play a role. So in this degenerate ankle, which later on turned out to be a rheumatoid ankle, the best thing to do was to have a microfracture done. And the microfracture played wonders for this patient. This patient is still doing good. In spite of losing almost half of the tibial articular surface, which you can see there, and that too on the talus, the debridement of the ankle is shown to have very good results. Case number 2. Now this is the posterior ankle scope. Now here what we are trying to see is excision of a Hageland's deformity. So that is the Hageland's deformity which you see, and there are certain angles which are calculated. So if you see here, you draw a line and then pass that line through the posterior superior aspect of the Hageland's deformity, and there is one more line which passes through the calcaneal inclination. So these were two angles which were suggested. One was suggested by Fowler Philip. The normal angle is 44 to 69 degrees, and anything which is greater than 75 degrees is called as an abnormal angle of Hageland's deformity, and the deformity needs to come out. This was further modified by Rush and Vega et al., where they found that there is a role of calcaneal inclination to play, and if this inclination angle is more than 90 degrees, then probably you're in for a symptomatic Hageland's which needs to be removed. So this usually is done in prone position. That's the Hageland's deformity. That is the typical OT setup which you do. And there was one more method which we presented in JOCR, which is called as all lateral portal method. And this was deployed in patients who had a very high BMI. The anesthetist did not allow us to make the patient prone. So we tried to do this in all lateral position. So patient was made to lie down in a sloppy lateral position. And this is how the surface marking was done. That is the tip of the lateral malleolus. That is the tendo-Achilles border. And the line which crosses this exactly into the corner is your viewing portal. So that is the portal which is taken from the lateral side, and alongside the same portal you take another instrument portal to do an Hageland's excision, as you can see here. So that is the way from where my scope is coming in, and this is the portal which is immediately next to the viewing portal, which is the instrument portal to take out the Hageland's deformity. So this was the paper which we published, and this was published in 2017 in JOCR. So if you have a look at the, again there is something wrong with the videos, I don't know. Okay, so I think let me just, can I just wait for a while and try and fix this up, or do we move ahead? I think we'll move ahead. So anyway, I'll show you that video again, but that is the post-operative result which you see. There's something wrong with the presentation, I don't know. Now I'm not able to.
Mr. Kshitij, can you
No.
help Dr. Pimprikar, sir?
Yeah, because now see, I have lost my presentation. So there is only part of it which is coming and part of it is not playing at all.
Mr. Kshitij, are you there?
Can you try restarting the presentation?
Yeah, I'll do that. I'll do that. Let me see. So,
Yeah, we are able to see now.
yeah,
I didn't see
correct. But then,
slide.
yeah. But what is happening is, it is not playing the media. So, in spite of having the backup files there, you know.
Yeah, now it has come.
Yeah. So anyway, what I'll do is, see now presentation. Are you able to see? You're not able to see, correct?
No, only case 3 written thing is seen.
Yeah, that's right. So we are not able to see the content. We are only able to see the media.
Yes, sir.
Yeah. So just give me a moment. Let me just try and fix this again. I'll
Yes, sir, sure.
open my presentation again. Let's see. So you're able to see the screen now.
Yes, sir.
Yeah. Hmm. There's something grossly wrong there.
Dr. Milind, can you try one thing? Can you open Keynote and try to play the same file with the Keynote PPT file?
I'll do that. Let me see.
Sir, if you have
Just give
separate
me.
folder for the
Yeah, it's a separate folder actually. So separate folder and I don't know, because this is in a hard disk where all the videos are actually in the hard disk itself, and there is no reason why it should not play. Okay, are you able to see this now?
Yes.
Yes, sir.
Okay, so let's go to the Haglund's video later. So I'll start with the case number 3. So that was Haglund's deformity, which was excised in all lateral position, and I will be in a position to show you that video in a while. So let's pray that this actually plays. So I'll go to the slideshow view and let's see if that happens. So this is case number 3. Now, how we can use ankle arthroscopy in such kind of scenario. So this was a fractured talus, which was open reduced and fixed at some other place, where you can see that there is a small Herbert screw which is being put onto the talar dome. So probably this was a patient who had an osteochondral fragment 2 along with the fractured talus, and there was a medial malleolar osteotomy done to fix this fracture. Now, as all of us, we know that talus is a bone which is very, very likely to go into AVN. So initially, in immediate post-op period, this patient did well. The osteotomy healed well. But as you can see, the screw started getting more and more prouder here. And in subsequent X-rays, when we followed him, we found that this screw had started abutting his ankle, and he had a severe pain into the ankle with synovitis. So we planned an arthroscopic removal of the screw, and this is what was done for this patient. Now this could be one of the indication which is difficult, but then yes, you can do it. So this Herbert screw was proud, and you can see the talar dome has completely undergone degeneration here. So this talus ultimately would probably land up with AVN. So initially we removed the screw, and since the bone had united, we thought in the betterment of the patient by doing a minimalistic approach, wanted to see if this patient is going to do well. And you can appreciate here, this much part of the talus is completely gone. So taking into consideration the principle of microfracture, we thought by removal of the screw, the microfracture is already done. Did a thorough debridement in this case, and patient was relieved for another, say, about 6 months, only to come back with the collapse of the talus. And this patient later on landed up with an arthroscopic ankle fusion. So whenever you're dealing with fracture talus or in trauma surgery, where you have fixed the talus, there is a high chance that it might go into AVN, and this implant removal or removal could be one of the ways by which you can treat them. So that's a chondral pick which is coming in. We had done a microfracture. Initially, patient did well. Some of them might do well if the talus does not end up with an AVN, and this could be one of the indications for anterior ankle scope. So this is how it progressed. Now you can see that the Herbert screw has been removed. Still, you can see that the contour of the talus looks intact, but finally it reached this position where there is a loss of ankle joint space. There are lytic shadows into the talus, and ultimately this patient landed up with an arthroscopic ankle fusion. So these are again subsequent X-rays. Can you see now talus has broken down there, and you can see that there are lytic shadows here. The joint space is being lost, and that's the last picture to show you that this patient then was taken up for ankle fusion. Case number 4, it's a 52 years male, history of RTA 9 months back, known case of DM, was treated outside with flap and open reduction internal fixation. Now complains of inability to walk properly. There is pain, swelling, but there are no draining sinuses. Now, if you have a look at this picture, this was the index presentation of this patient, and this patient was treated outside with kind of a situation like this. You can see that there is a pin which is transfixing from the calcaneum into the talus, but this probably because of the severity of the injury, the orthopedic surgeon treating this patient resort to this minimalistic fixation, and the plastic surgeon did a flap on top of this. Now, when this patient presented to us, the ankle joint had completely gone bad, and there was no option left than to do an ankle fusion in this situation. When the patient presented to us, all the implants, they were removed, although there was a small wound on the calcaneum from where the pin was put in. And if you see in this situation, okay, so every time it is asking me to grant the access for the videos. That's fine. So that's how the ankle looks. So this is the arthroscopic ankle fusion. That's how the ankle looks. You enter the ankle joint, you know nothing. It's all fizzy there. You don't really have any clarity, but you have got to keep patience to perform an ankle arthrodesis. Sometimes it is difficult to enter the joint. You cannot even insufflate the joint with normal saline. And now you can see onto the talar dome, that's the hole which is made from the calcaneum. Now this is a source of infection when you have a patient who's diabetic. The cartilage on the talus is completely eroded. And again, as I said, with whatever instrument, whatever equipment you have at your hand, you need to really debride these defects well to expose the subchondral bone in order to have a proper ankle fusion. So this debridement takes a lot of time. Normally, on an average, this might take you about 30 minutes to clear off all the cartilage from both the bony surfaces. And you can use whatever instrument at hand, as I told you, the curate, the osteotome, maybe the acromionizer, and then you're trying to make all the bony edges fresh so that the fusion progresses without any issue. Another thing which I would like to highlight here is you can see that there is a lot of space now. It's a 4.5 mm acromenizer which I have pushed into the ankle joint. So if you go slowly and keep on making space there, you can definitely have a lot of space to work. You can see a bleeding bone there. So I have gone up to the subchondral bone and I have removed the cartilage as well as the debris very meticulously. If you are able to do this properly, arthroscopic ankle fusion is one of the best indications for ankle scopy, and it really gives you very good results. You can see a little bit of cartilage left there, which also I have removed at a later stage. And then what I have done is I have also debrided this, entering from the calcaneum, pushing in a Steinman pin or a switching stick, and then putting in a shaver, because this probably might harbor some kind of microorganism. So that's the switching stick coming in, on top of which I put my shaver and clean the whole surface. Now you can see I'm putting 6.5 mm screws for fusion, and these are guide wires. So you can even push guide wires under the vision so that it crosses your both the bones properly. And these are the screws inside. So once you have done a fusion, you can also see the screws passing into crisscross fashion to give rise to a good ankle fusion there. So this is a good procedure with good results. We have done at least about 12 ankle fusions now. So those are the amount of screws which we have put. And since this is an enlarged image, you can see that probably it seems that the space is too large, but it is not so. So this is how is the picture of the outside picture when you're seeing it from inside and passing the guide wires in different directions. And that's it. That is how is the post-op picture, where you see that there are 4 screws which have been put, and you see that there is no space left. So it has been nicely compressed there. Ankle fusion is a wonderful procedure. And to just highlight that, how the ankles they look when you have a absolutely degenerated ankle, this is another case with the same kind. Now, no sooner you put your scope in, you see that there is nothing there. It's all fluffy, and you don't really get to know head or tail that where your shaver and where your equipment is going to be. But if you're a little more patient and if you're trying to shave off the tissue, so see in this another case where again this patient underwent ankle fusion. So that's a lot of space there. Initially, you might feel the space is less. Now here, see the acromenizer is roaming inside the ankle joint. So if you're a little slow, little patient, and you're debriding it pretty well, making space for yourself, then this is the amount of space which one can get whenever you're doing an ankle fusion. So a wonderful procedure, and it is way better than you do as an ankle, as an open ankle arthrodesis. Plus, the time taken for this surgery is not more than an hour. So I think it stands the merit of time utilized as well. So case number 5. This is a 45 years male, history of recurrent ankle sprain. So here we move towards the lateral ankle instability. And what I want to highlight is this is not an arthroscopic procedure, but this is arthroscopy assisted procedure. And now the arthroscopy surgeons or foot and ankle surgeons have started doing arthrobrostrums. I have not shifted to arthrobrostrums, but I've been treating these patients arthroscopy assisted, first getting the arthroscopy done and then doing a mini open Brostrom's procedure by using internal brace. Now you can see that is the MRI picture. No ATFL there. There is a bone edema, and that is actually so again the same problem. I don't know why this is happening, but anyway, this is not going to play. So what I want to emphasize here is, if you see the lateral complex, the calcaneofibular ligament is at an obtuse angle. So you have a ATFL running there and you have a CFL running in that fashion. So if you are reconstructing both, that is ATFL and CFL, then you need to see and you need to understand at what point you are going to insert your suture anchor. So okay, that was an animation. So that's the mechanism of injury which you see for ATFL and CFL. That's your ATFL going there, that's your CFL. And the point to really note is that an obtuse angle. So those are the basic clinical tests which we do for ATFL injury. That's an anterior drawer test that talks about medial laxity. That's a talocrural laxity. We can do it in 2-3 positions. I will not go into the details. And that is the animation which tells you that how you reconstruct your ATFL and CFL. We have done almost about 15 15 Brostrom procedure using the internal brace. That's the needle which goes in, and that is the typical setup. So that's how you perform an anterior ankle scope. And if you see this, that's how it looks. Now, why I've put up this video is it is mandatory for us to do an ankle scope before we do a Brostrom procedure to see the osteochondral lesions and to see some bony contusions. Now here, if you see that there is a lot of cartilage injury onto the medial aspect, so this area needs to be cleared off, shaved off, and there was a small bony fragment lying there, which also you could have seen that into the MRI scan. But that's the debridement of the joint which one needs to do whenever you're doing a Brostrom procedure. That's a small osteophyte impinging there onto the medial side. So use a small osteotome and remove that fragment as well, because this was a chronic ankle instability. Then you examine the whole thing, you examine the gutters, and then go ahead and do your Brostrom procedure. So I usually do Brostrom procedure with this knotless anchor, and this is a small anchor. This is 3.75 anchor, which is made by Arthrex, and there is a definite sleeve which can be used. So as we know that ATFL starts from the tip of the fibula, and it is within 1 centimeter of the distal fibula. You mark the ankle in this fashion, and then that's the incision. Once you take the incision, you reflect the whole of the ligamentous complex as a periosteal flap. So that's the periosteal flap which has been raised, and I'm sorry for that, but then I can't help that. Something is not really working today. Yeah, okay. So that's the anterior drawer. Normally you should do anterior drawer with the knee flexed to 90 degrees. That's the way how you open the skin and fascia. And then in the line, you have to clear off the tissue over the distal fibula. And a double breasting is carried out as you do it. As you do it as a general surgeon, we do it in hernias. So that's a fiber wire. We have inserted 2 suture anchors onto the distal fibula, and a double breasting is done of the whole ligamento-capsular complex, and this is double breasted to the suture anchors which one have put into the fibula. I'll just make it a little faster, and you have done that. And once you have tied them, that's the internal brace which we are going to use. So I just want to show you how we use that internal brace with a fiber tape. Now that you can see a fiber tape there. So once double breasting has been done, you use these knotless anchors on both the sides. So you have got to identify the point onto the talus, taking image intensifier control. And that's the first suture anchor which goes in with the fiber tape. And that's the second one. So that's onto the talus. So you mark the fiber tape so that you don't over constrain the ankle. And when you are fixing this, you should put the dorsiflexion and everted position to have adequate tension over the ankle, and that's the final result. So the anterior drawer test on table, you can see, will reduce to almost about grade 0, and that's how you see a fiber tape, which is fiber tape should never be applied onto the bone directly. It should be applied after you repair the ligamentous complex, and that's how the X-ray would look like. Those are 2 anchors which have been used, one for CFL, the other for ATFL. Now that's the hole onto the talus, and that's the hole onto the calcaneum. So that was the ATFL, that was the CFL which was reconstructed using fiber tape. That's how the post-op picture looks like. These patients are put into slab for next about 3 to 4 weeks time. And that's the air cast brace, which is worn for another 2 months, that is up to 12 weeks. And then patient starts with the physiotherapy and rehab. Case number 6 is a 56-year female, pain since 6 months, swelling towards the end of the day, inability to squat, posterolateral tenderness, TA was intact, no DNVC. Now you can see here, this is os trigonum, and there is a loose body which is present here. And the patient was in severe pain, was not able to walk at all, and came with severe agony. So this is one good indication to do. I have put this video, the Haglund's video, I'll show it to again. But since there was a Haglund's video, I have not completely done this. What I want to show you, that is in os trigonum, and you will see tendinotic changes happening into the FHL tendon. Now you see that is the region from where I have removed the os trigonum. Oh my! So that is the excision of the os trigonum, which is already done. I have a shaver inside. These are all knee equipment. There is no specialized equipment which has been used. This is the medial side. This is the lateral side. Now, as I move onto the medial side, you will see the tendon of FHL comes in your view, and this tendon needs to be protected. At the same time, this tendon needs to be decompressed, because you will see. So I'll just take it ahead a bit. Yeah. So see, that is the tendon of the FHL, and it is immediately next to the os trigonum. That is the tendon. You hook the tendon up, it is tendinotic, and try and flex the great toe. And you'll see that is the FHL tendon passing below the sheath there. So here the tendon gets entrapped, and these patients also have a lot of pain at the time of extension of the great toe when you have os trigonum. So here you have got to decompress this tunnel. The tendon is not looking very healthy. So with the use of a shaver, go to the roof, and you can shave off the roof to make the tendon excurve in a proper way, so that there is no pain. So along with os trigonum, make it a point to always look for the tendon of the FHL, and if there is any impingement or if there is any restriction into the tunnel, you need to really release this tendon. So this is the release which is being carried out. You can see, you can push your shaver in and just de-roof the tendon there. There is a bone which is present on this side, which was later on removed with the help of an osteotome, so that the tendon has got a very free excursion. So this is, you can say, a tendoscopy, but not tendoscopy in isolation, but we have to see for the tendon of FHL whenever we are dealing with this kind of a pathology. So that is how it is now. It has been thoroughly decompressed, and the tendon looks pretty okay. So there the osteotome comes in, and then I have removed this remaining portion of the bone which was there. So that was the os trigonum excision, and that's the osteotome removing the bone, and that is the final picture. You don't see any loose body, or os trigonum has been completely removed from this place. And the last case, case number 7, I don't want to trouble you more, but this is pain posterior superior heel. Again, this is a Haglund's patient, but she had a sudden pop 3 months ago, was unable to walk properly. There was a localized swelling and tenderness with minimal fluctuation. Thompson's test was negative. Now, what I want to make a point is, you can see a broken calcaneal spur here, and these patients will have Haglund's deformity, but they will also have Abel's tendon. Sometimes the Thompson's test may be negative, and as you can see here, this is the Abel's tendon fragment. These are contraindications for endoscopic Haglund's disease. Intratendinous calcification should be viewed with a suspicion, and as the literature quotes and everybody says that in all such situations, you will have to take down the tendon and re-repair it. You can see a portal there. So in this patient, what I did was, initially we did an arthroscopy and removed the Haglund's bump, and then we did a open surgery where we used the shoulder instruments to pass the sutures. So as this is an enthesopathy, retrocalcaneal bursa and TA tendinopathy is enthesopathy, it functions exactly like a rotator cuff. So what we can do here is, we can repair this tendon as we do a double row repair in rotator cuff. So we used a self-retrieving instrument, and we took the medial row anchors with the help of this instrument, and those are the medial row anchors which have been taken. So medial row was tied with the mattress sutures here. Then rest of the sutures were used to suture the paratenon. And then at last, this was sutured onto the calcaneum in a double row fashion. So there was a medial row repair, and using this there was an anchor which was pushed in, absorbable one, to make a double row repair. So whenever you have a avulsion of the fragment, one needs to understand that these fragments, they should be refixed after taking down the tendon. If you So I'll just show you two there's something happening which I'm so sorry, I'm taking too much of time as well, and this is not not going to the mark.
Sir, meanwhile, you can take some questions from the participants.
Yeah, please go ahead. Please go ahead.
So Dr. Rajiv Shah sir is asking that open tendon repair versus the SCOPY tendon repair. What's the advantage of the SCOPY?
So this is not an endoscopic tendon repair which we have done. What we have done is, that is what I'm coming to. So I'll come to that case. So yeah. So you're able to see the screen, right? Are you able to see the screen?
Yes,
Yes, sir.
Yes, sir.
Yes, sir.
Yeah. Now see, have a look at this video. Now something was happening in that presentation. Now see, this is the same patient. Now what I've done is, in prone position, I'm doing endoscopic Haglund's excision, because more often than not, the calcaneal spur, which is the avulsion of the tendon, and the Haglund's deformity will coexist. So if you see here now, this is the Haglund's bump in the same patient. And what the point which I want to make is, I am excising this, which I normally do it with an osteotome. So I'll show you once this has been excised. Patient. So that's the excision of the Haglund's bump in the same patient. Okay, so I'll just make it a little fast. So that's how I do it. I push in an osteotome, so it's a 3-minute job. Since it is an exostosis, it's a loose tissue. The moment you put your osteotome in, the bone fragments, they really start falling apart, and that's how it happens. So that's the excised Haglund's bump now. And now I'm going on. Can you see that? Oh. I'm going on to the tendo achilis side. Superiorly, you have tendo achilis. Here is your Haglund's bump. So I'm making the edges smooth. So in a normal Haglunds, now there I go, in a normal Haglunds, you won't be able to go beyond this. Since there is a tendo-achelis avulsion here, there is a lot of space between the tendo-achelis and your calcaneum, and you can see you can lift up the whole tendo-achelis, and that's a bony fragment, which is an avulsed fragment, which I'm lifting up with my radio frequency probe. So during surgery, if you see that there is a lot of space which is left between the tendon and the bony fragment, a suspicion should be raised that probably there is avulsion of the tendon too. So it's not enough to do only Haglunds. In that situation, you should open, you should examine the tendon, and partially avulsed tendon should be repaired by open method. So can you appreciate that? That is the edge of the Haglunds. You cannot go beyond this normally. So there I am able to lift up that bony fragment. So that is what I wanted to show you.
Yes, sir.
Yeah. So that was the one. And second, which I missed out, was this is the Haglunds calcaneoplasty. Now this is done in lateral position. So I'll just orient you. This is tendo-achelis. Red thing is a retrocalcaneal inflamed bursa, and this is the Haglunds deformity. So as you go in, you start seeing this. Now this is what I wanted to embark upon. This is the tendo-achelis. This is the bump. You won't be able to go beyond this if the tendon is intact. So that point should be always remembered. So whenever you're doing an endoscopic calcaneoplasty, if you're able to cross beyond this point, probably the tendon is avulsed. And this should always be considered whenever you're doing this. So that's the tendo-achelis on top now. To orient oneself, what normally you can do is you can pass in a 18 number needle from there so that you know where the tendo-achelis is. And push in a shaver. Now this I'm doing in a lateral position. These are all lateral portals there. The case which I showed you, but the video was not playing. You can rotate the cable and orient yourself to a prone position so that now the tendo-achelis is superior and the Haglunds bump is inferior. You have to take the radio frequency probe or a shaver and delineate the deformity from medial lateral side. Now see, I'm trying to delineate the deformity. This deformity can be identified by a cartilage in a scap, and then under image, you just push in a small osteotome. Don't try to do it with a burr or don't try to do it with a shaver. Just push in an osteotome, and you can walk from lateral to medial side very safely and take out the whole Haglunds bump in one go. So can you see that? So that's the way, and it is very simple, about 5-minute job. And then after that, you have to round the edges of the deformity here to have a cosmetic look onto the X-ray. Otherwise, the patient might ask you, "Doctor sahab, aapne to nikala hi nahi hai." And this is again a point which I want to make. Can you see? This is the edge of the deformity which is removed, and that's the tendon on the top. No space between here. So if you have a space between there, take down the tendon and repair it. So answer that question. This is not an endoscopic repair of the tendon. I have used endoscopy to remove the calcaneal bump, because then probably the incision which was required would have been much bigger than I did it. And the repair of the tendon was essentially done by an open method. In that situation, what the video which again did not play was this. So see this. So once you have done, with, that's the all which is coming in. Okay, so I'll just go a little fast. That's the last video. So there, and I fixed this with a swivel lock anchor. So it's a nice double row repair. The medial row, you push in one anchor, and this video was not playing in my presentation, so I opened another presentation to show you that. And that's how it goes. So there are various ways by which you can do this, and this is one of them. So I think with that, I would conclude my talk with some case presentations. I'm so sorry this was not up to the mark as I thought. Sorry for the inconvenience caused.
Sir, it was a privilege to hear from you, and it was an academic feast to see all the videos. Thank you, sir. Now, Dr. Pranav Patel, are you ready with your wrist presentation?
Yes, I'm ready with my presentation.
Okay,
Meanwhile,
Dr. Pranav,
if
you can start
the
sharing
participants have any questions, Mehta Sahib?
I think Dr. Raju Shah is asking question about the role of endoscopy while repairing the this diseased tendon. He says, according to him, there's not much of a role doing an endoscopy when you're going to do an open repair.
That's question for me.
Yes, sir. Yes, Billy, sir.
So you're asking me whether it is possible to do a endoscopic TA repair.
No. Dr. Raju Shah is there as an attendee, and he has put his question on the chat box.
Yeah.
That
Okay.
the calculoplasty is not a good option when you're doing an open repair of a diseased tendon.
Okay. So you should not. I mean, the question is, you should not combine two procedures.
Yes, especially when there's a diseased tendon.
So then, what are the options?
So when there is a diseased tendon, you just have to go in and do the open procedure. Adding an arthroscopy plus going ahead with an open procedure is an additional trauma. And for me, the endoscopic calcaneoplasty indications are: number one, if the disease is not there in the tendon, which I confirm by clinical as well as MRA examination. And number two, I always inject a local anesthetic anterior to the tendon. If it relieves the pain, that is the indication for me to go for endoscopic calcaneoplasty. When the slightest disease is there in the tendon, that's a sheer contraindication for me for going ahead and doing endoscopic calcaneoplasty. And going ahead with endoscopic calcaneoplasty plus opening, to me, has I think additional trauma to the patient.
Okay. So wonderful comment. I take that comment completely. We have our indications of doing endoscopic calcaneoplasty as selective posterior-superior tenderness with swelling. These patients routinely undergo not MRI, but they undergo ultrasound examination to see whether there is a intratendinous calcification. If there is intratendinous calcification, it is not an indication for endoscopic calcaneoplasty for us. You inject local lignocaine anterior into the bursa to see whether there is a retrocalcaneal bursitis. Now, if you consider pathology in this area, there are three things which we are dealing with. One is Achilles tendon tendinopathy, second, which is insertional tendinopathy, which is associated with a calcaneal spur with a tenderness onto the calcaneum itself at the attachment of TA. Retrocalcaneal bursa, where there will be swelling and there will be posterior-superior tenderness, and Haglund's bump is associated with retrocalcaneal bursitis. If you see the literature, two conditions, that is retrocalcaneal bursitis along with Haglund's bump and calcaneal spur, more often than not will coexist. But seeing a retrocalcaneal spur, which is non-symptomatic, that means you have tenderness only at posterior superior aspect of the calcaneum, is a good indication according to literature as well. Now, I would agree to disagree on your point that you are inflicting more trauma by doing an endoscopic Haglund's excision, because it's a minimalistic approach and anyway you're going to open. So Haglund's, if you remove it endoscopically, it is in fact less trauma than doing a complete open. When there are changes of tendinosis on an ultrasound, it is not a good indication for isolated Haglund's excision. It needs to be done with detachment of the tendon, debridement of the tendon, shortening of the tendon at times, and a proper open repair. But Haglund's, removing Haglund's endoscopically, I don't understand how will it inflict more trauma. So those are some of my comments on what you have said. Although your points are absolutely well taken and they are absolutely with the science.
And one question, Dr. Milind sir. How to take this posterior medial portal for removing the Haglins? What is safe
So
way of
if
doing
you're
it?
doing it in a prone, yeah. So if you're doing it in a prone position, so as an orthopedic surgeon, we know that we would like to stay close to the bone to avoid injury, right? So stay close to the bone. So you will avoid injury to rest of the structure. So here the key is I don't really rely on any set landmark. The lateral, once you are pushing a scope from the lateral side, along with the trans illumination at the edge of the tendo achelis onto the medial side, if you take your medial portal, it will never ever hurt your posterior tibial structures. You are far away from it. The only thing is, by pushing in a needle, always check the trajectory which you are going to get best for instrument to be pushed in and to address the deformity. Once you have done that, I think paratendinous portal onto the medial side, at any place wherever you like, you can take it.
Thanks for that.
So I don't set any fixed landmarks.
So I think we can go ahead with the next session.
Yeah, Dr. Pranav Patel, you can proceed with your talk on wrist arthroscopy.
Yes. Can you see my screen now?
Yes, we can see your screen.
Yes, sir.
All right. So good morning, everyone. So I'll be talking on wrist arthroscopy setup and portals. So first we'll see the setup. Now wrist arthroscopy, as we know that shoulder arthroscopy can be done in two positions, that is in the beach chair position and in the lateral position. Similarly, the wrist arthroscopy can also be done in two positions. That is one is which is shown here. That is the full supine, full extended arm at elbow, and second position is the hanging wrist position. So if this is being, if the wrist arthroscopy is being done in association with any fracture or something, then this is the position which is required, where a surgeon is towards the head side, the nurse is towards the finger side, the assistant and the image intensifier is towards the ulnar side of the patient, and the tower is the arthroscopy tower is kept on the opposite side. But when it is done purely for only the arthroscopy of the wrist or any wrist soft tissue pathologies, this is the position how we do it. That is the hanging wrist position, wherein the wrist, the hand is held by a shoulder traction stand. The anesthetist is at the head end. The surgeon is here at the towards the thumb end. The trolley is here, and the assistant is towards the ulnar side of the patient. The Mayo trolley, which is height is adjusted of the Mayo trolley, is kept over the abdomen, where we can put all the arthroscopy instrument, that is the camera, the shaver, and all connected instruments can be put over the abdomen. This is how the hand is held, and here the arthroscopy trolley is kept. This is the finger trap. So basically, holding the hand, there are a lot of different equipments and instruments available to hold the hand in the position. So this is the Chinese straps which are available. Then there is a hand board which is available for holding the hand. And similarly here we can see the fingers are held by all the fingers are held by the Chinese strap. So what happens is when we are holding the wrist in this position, we need some amount of distraction at the wrist joint. So it can be done in two ways. Either it can be the arm can be tied at the board, and then the traction can be given by the stand which is suspending the wrist, or that hand can be tied with the stand, and traction can be given at the arm level. So if at all we are whenever we are trying the wrist, the arm at the hand board, there is the main thing which we need to see is that the bandage which we are tying, this bandage which we have tied here, it can roll up and cause some amount of constriction. So I use always two tourniquets, wherein this tourniquet is connected to the machine, that is for the tourniquet, and the second cuff is not connected to any machine, but it is just kept so that the bandage does not cause any constriction over the arm. So now you can see that this bandage is tied over the tourniquet and the weight is hanging on that. So even if the bandage converges at one point, it will not cause any constriction band over the arm, and the patient won't be getting any another problems. So this is what the Chinese strap, the finger knot which I have talked about, and this is what the different kind of sets for holding the fingers are available. If we are using Chinese straps, then there are two to three positions in which we can hold the hand, depending on the procedure which we want to do. We can use it for either two fingers, that is the index and the middle finger. We can also use it for the ring finger as well, or we can use it for all the fingers as well, depending on what position is required during the surgery. So there are different types of traction sets which are available. So these are the ones wherein the hand will be held, the arm will be held in a counter traction position, and the stands will be giving the traction with weights. This is also a band. There is also a band available which can help you in hanging the weights. This is a self-giving traction stand wherein there is a counter board available and the traction stand available in itself, where you can adjust the traction from this module here. So this is the final setup wherein the hand is held with the shoulder stand from here, and the weight provides counter traction towards to the wrist, where we get some amount of distraction. So instruments, coming on to instruments, where we need arthroscope, which are small joint arthroscopes, that is from 2.4 to 2.9 mm. Usually I use 2.7 mm arthroscope, which is 30 degrees angulated. There we have the blunt trocars and the cannulae. The forceps and the graspers which are available are for small joints are different, which are small in length, and their mouth openings are also small, because usually what happens is the instruments which can enter into the wrist joints are almost like not mm or 3 to 3.5. Have small mm. So we have shavers as well. The probe which is used, that is the finger probe which is used, it is almost in diameter. One second, I think there is some problem with the network. Yeah, can you hear me now? Aditya, can you hear me?
Yes, I can hear you, Pranav.
Yeah, proceed.
Okay,
Pranav,
okay.
carry on.
I thought that I'll just, yeah, okay. So my presentation has stopped moving, just a minute. My presentation has stopped moving, just give me a moment, please. Oh yes, now it has started moving. So instruments, the probes are all 3 mm probes, because and the shaver hand pieces and the shavers are not the ones which we use regularly in our knee and shoulders. They are very small in size. Of course, the radio frequency ablators are the ones which we use regularly in the knee and shoulders. So coming on to the basic anatomy, in wrist joint, we can do arthroscopy at two levels, that is the radiocarpal joint and the midcarpal joint. So radiocarpal joint, here we have the articulation between the radioscaphoid, radiolunate, and the ulnar triquetrum, and then there are the midcarpal joints where you can do the arthroscopy as well. The main anatomy which is important the compartments of the dorsal side, which we should keep in mind. So there are total 6 compartments in the dorsum of the wrist. That the first one will have the EPB and the APL. The second one has the ECRB and the brevis and the longus. The third compartment has the extensor pollicis longus. The fourth compartment has the digitorum communis and the indicis. The fifth compartment has the digiter minimi, and the sixth compartment has the extensor carpi ulnaris. So basically, these are the powerhouse of the wrist joint arthroscopy, wherein we need to understand where all of them are there. And the most important point for wrist arthroscopy is the Lister's tubercle, which is seen as a star in this slide. So the next point which we need to understand is that the extensor pollicis longus, which is here at near the Lister's tubercle, it does not go straight towards the joint, but almost all the other tendons go straight towards the joint, but the EPL, after crossing the Lister's tubercle, it deviates towards the thumb, and hence, so once it crosses near the joint, it has almost crossed the Lister's tubercle and it is going towards the second compartment. So this is the main point in which should be kept in our mind. So any small joint arthroscopy is not complete without surface marking. Surface marking is very important in small joint arthroscopies, because once the joint starts insufflating, it is very difficult to get the landmarks again, and we are dealing with a lot of tendons here on the extensor aspect, and so we do not want anything to be damaged. So first we need to mark all the points, that is the Lister's tubercle, the radius with the styloid, the ulna. We need to mark the carpi ulnaris. We need to trace out the extensor pollicis longus. All of them needs to be marked out, and mind you, these points have to be marked only after giving the traction on the wrist joint, because once you do it without traction, these points can move after you give traction. Maybe if they might move only for 2 to 5 millimeters, but with these amount of tendons going around the wrist joint, it is very important to mark your points after you give the traction. So coming on to the portals, there are dorsal portals and there are volar portals. Volar portals are not of so much of use, because almost all the arthroscopy of surgeries of the wrist can be done by can be finished by dorsal portals. We have seen all the 6 compartments, and so now we can divide all the portals with names that they go in between the compartments. So the first portal, that is 1-2 portal, it will be go, as the name suggests, it goes between the compartment 1 and 2. So 3-4 portal goes between the 3 and 4 portal here. The 4-5 portal is between the 4th compartment and the 5th compartment. The 6R and 6U, so this is 6R, the 6th compartment has 2 portals, that is 6R, which is on the radial side of the extensor carpi ulnaris, and the 6U is on the ulnar side of the extensor carpi ulnaris. So here we see that somewhere over here there was the Lister's tubercle, the extensor pollicis longus has almost curved almost towards the second compartment, and hence the third compartment is over here. So once you have marked your Lister's tubercle, once you have marked your distal end of radius, the border, then there always we have all joints have soft spots. We have the soft spots in the elbow, we have the soft spot in the shoulder. Here also in wrist we have the soft spot that is around 1 centimeter distal to the Lister's tubercle, and that is the point where our 3-4 portal enters. So if we look at this slide again, and if we see where all the portals will be entered, it will be between the 1 and 2 compartment. So then the EPL will be turning towards the thumb. So the 3-4 portal will be almost at the level of the Lister's tubercle. 4-5 portal will be between the 4 and the 5th compartment. 6R will be on the radial side of the extensor carpi ulnaris, and the 6U will be on the ulnar side of the extensor carpi ulnaris. So this was at the level of the Lister's tubercle. When we go towards the joint, and if we stay oriented to this part of this side of the wrist, then again we can see here that the 3-4 portal is coming in from here, 4-5 portal is coming in from here, 6R is coming in from the ulnar side of the ECU, and the 6U is coming in from here. So this is the radius showing the scaphoid fossa, the lunate fossa, the TFCC, and the ulnar end. So other portals which are available for wristscopy on the dorsal side are the mid-carpal radial portal and the mid-carpal ulnar portal. Then there is a scaphotrapezio-trapezoid portal, which is between the scaphoid, trapezium, and the trapezoid. Then for the DRUJ, we have three portals, that is the distal, middle, and the proximal portals. We have some portals for this first CMC as well, but they are very seldomly used. These are the ones which are telling you that the distal DRUJ, the middle DRUJ, and the proximal DRUJ. This is the mid-carpal and the mid-radial portal. So if we try to find out the if we have the Lister's tubercle here, that is one position of these, the 1 centimeter distal is the 3-4 portal, and again if you go 1 centimeter distal, then there is the mid-carpal radial portal. Distal to that is your portals of to complete volar. So once I have told that we need to mark all our points after we have given the traction, then once we have seen the 3-4 portal, once we have seen the soft spot, we identified the soft spot, we have to insufflate the joint with the saline of 10 cc. This only the superficial skin incision is taken, that is in the line with the extension tendons. But because if we go perpendicular to the cross section of the tendons, then we might cut any of the tendon. This applies to all the portals entry. Blunt dissection is done with the hemostat, and then the joint is entered with the hemostat. So here you can see that there is this is the Lister tubercle. We are going 1 centimeter distal. Then there is a joint insufflation, the skin incision, soft tissue dissection with the hemostat, and then entering the joint. Now, mind you, there is a tilt in the radius, and so if we enter the joint straight into the enter the wrist joint straight, you can always go and hit in the carpal bones, and it will go on injuring the joint. So whenever you are entering either into the radiocarpal joint or into the mid-carpal joint, it has to be in an angle, because there is a dorsal tilt of the wrist joint, the radius. So it has to be always in the angle up to 15 to 20 degrees on both the joint entries. So last but not least, the points to be remembered are: mark your bony landmarks after traction, entry in the joint keeping in mind the radial tilt. The viewing portal is always a 3-4 portal. The instrument portal is the 4-5 portal, the 6 radius and the 6 ulna portal. And sometimes what happens is, when you might not have the cannulas which are having inflow or outflow, then you can use the 1-2 portal with for an inflow or outflow by a 18 gauge needle. Thank you.
Thank you, Dr. Pranav. Now I invite Dr. Abhijeet Wahegaonkar, sir, for his presentation on indications and patients for wrist arthroscopy.
Thank you. Thank you very much. Can you?
Yes, sir, we can hear you.
Yeah, you can hear me? Great. I'll share my screen.
Yes, sir, we are able to see your screen.
Okay, great. So just give me one brief moment and we're going to start it. Can you see my PowerPoint now?
Yes, sir.
Okay, so thank you very much. I would like to acknowledge the Baroda Orthopedic Association and my friends and colleagues, Dr. Aditya Agrawal and Dr. Pranav, for the opportunity to speak here. And it is indeed a privilege and an honor to be with you all. So my task is to take further what Pranav has already spoken about, and I'll be talking about the indications and how far can we go with wrist arthroscopy, and I have no relevant conflict of interest. So when we speak about small joint arthroscopy, we are talking about these joints that are listed in this slide. We're talking about the wrist, we're talking about the thumb. People are also now doing arthroscopy for the MCP and the PIP joint. We are talking about endoscopies. And we're talking about the foot, which is beautifully demonstrated by Dr. Pimprikar sir, and also the TM joint. So all of these scopies have one thing in common, is that they need a small joint scope with a preferably a small barrel scope, and it requires a thorough understanding of the anatomy and, of course, training. So the history of wrist arthroscopy kind of goes back to the 1980s, when investigators from the US, Europe, and Japan started looking into the possibilities of extending the diagnostic indications to therapeutic indications. And then it really started blossoming late in the 21st century, when all these investigators have added to a fund of knowledge and have really made wrist arthroscopy a very exciting proposition for our patients. So why small joint arthroscopy? If you look at this particular slide, you see a picture of a man trying to peep into the eye of a needle. And if you zoom into the eye of the needle, you see this beautiful artwork in the eye of the needle. So wrist arthroscopy does precisely that for you. It magnifies the view inside the joint, and with beautiful optics and high resolution cameras, this has just made visualization of small joints a lot more fun, and the instruments that are developing are adding to our armamentarium of extending the indications for therapeutic procedures of the wrist joint. And way back in 1979, Chen mentioned that wrist arthroscopy was a gold standard for diagnosis. However, as we stand a few years down the line, about 30-40 years down the line, we are now talking more of therapeutic indications, and this is perhaps a gold standard for therapeutic indications also. So brief review of the indications for wrist arthroscopy are listed in this particular slide, and I won't belabor too much on this, but this particular slide will help you understand the therapeutic indications a little better. And if you classify them as soft tissue and bony procedures, we can classify them as ectomy procedures, like removing something like a proud osteophyte, maybe it's the removal of any arthritic or chondral lesions, debridement, and so on and so forth. We can classify them as tissue shrinkage procedures, surgical release procedures, and reparative as well as reconstructive procedures. So we have come a very long way, and it is remarkable that we can perform so many procedures, and the list is still expanding with all the great minds who have devoted themselves to wrist surgery and wrist arthroscopy, elaborating more and more indications in quotidian practice. This was a paper that was published by my mentor, Professor Smit Matalia, and this slide is kind of self-explanatory in highlighting the tremendous amount of advances that have been made. So when they looked at 2,000 cases, they found that 38% of these cases accounted for ligament injuries and repairs thereof. And then about 11% were indications for arthroscopy assisted fracture reduction and fixation, about 18% were for ganglion excisions, and then about 16% accounted for other miscellaneous indications that could be performed arthroscopically. So let us talk about the most common indication, and that is TFCC repair. And obviously TFCC stands for triangular fibrocartilage complex. And this particular video will help you understand the arthroscopic view of a peripheral tear of the TFCC. And this is called as a hook test, wherein we can put the hook underneath the TFCC and lift it off. So if I were to draw a schematic diagram of this particular tear, So this is the distal radius, and this is the ulna here. The TFCC comes and attaches like so, and there is a distal insertion and a proximal, so it's like a Y. So the tear is somewhere here, okay, to the dorsal capsule. So this is the dorsal capsule, this is the TFCC. What you see here is a pre-styloid recess, or the 6U portal will be located somewhere here, and the hook probe was coming in through the 6R portal, or you could even use the 4-5 portal. So let me play that video for you again very quickly. So my hook probe is coming in from the 6R portal. I'm visualizing from the 3-4 portal, and this is what a peripheral tear of the TFCC would look like. Now this video will help you understand how we embark on doing a arthroscopic repair for the TFCC. So obviously, before we perform any procedure under anesthesia, we like to ascertain the instability in all 3 rotations, that is to say pronation, mid-prone, and supination. And then we use standard wrist arthroscopy setup with regional anesthesia. There are people who do this under local anesthesia, such as Dr. P.C. Ho from Hong Kong. And here you can see the Lister's tubercle and the styloid process of the ulna being marked. That would give you a clue to the distal aspect of the radius. Once you have all these bony landmarks, it is easy to identify the extensor pollicis longus, the second and the third metatarsus, and each view would be just dorsal to this process with the forearm in pronation. Once you have all marks, we now can very easily palpate the soft spot, which is just distal, about a thumb breadth distal to the Lister's tubercle, and that is the 3-4 portal, or the primary viewing portal. I like to mark all my skin markings with the traction in place, because if you do that before the traction, the stretch on the skin will cause a distortion of the landmarks. We bring in a hypodermic needle to insufflate the joint with about 3 to 5 cc of saline. We should be aware of the radial tilt inclination, and the needle goes parallel to the articular surface of the radius, and you can see the piston push back and the fluid egress. That good idea for people who are beginning sojourn in wrist arthroscopy to use longitudinal plunge hemostat inside the joint with the index finger serving as a stopper, and you can feel the pop. Then you bring in your scope just like so, and you are ready to go. Every diagnostic scopy or every arthroscopy begins with a diagnostic round, and 20 years down the line, I still follow the same protocol. We first look from radial to ulnar, from distal to proximal, soft tissue first, and then the bony or the articular surfaces, and we then move on to the mid-carpal joint. Here I am now placing my outflow portal, 6U portal, that's where the hypodermic needle is. The valve is placed under direct vision, and then again, to accomplish that, I bring in a another needle through the 6R portal, where I can find a good location. I can sweep the needle so that I know that my instrument will have adequate space to move. Here you can appreciate that there is a dorsal. It cause any bleeding as you go through your arthroscopy. Again, a curved hemostat comes in. You feel the pop as you direct the hemostat inside. Note that this portal is a little proximal to the 3-4 portal because of tilt or inclination. And then again, the same view of the tear. This is a peripheral tear, and once you have identified the peripheral tear, you will set about your therapeutic steps. We bring in a small joint shaver, and you shave off any fibrotic or scar tissue so as to create bleeding surfaces, if you will. You remove any synovitis or synovial thickening that you may encounter. And now I'm going to show you something called as a suction test. So as you put the suction on, the entire TFCC gets sucked in, and that again that is a tear of the TFCC. So this was a test that was published by my friend and colleague, Dr. Sanj Kacker from the Mayo Clinic. So this is a neat trick. So besides trampoline test, you have the hook test, the ghost sign, and the suction test to ascertain that there is a tear of the TFCC. I'm sorry about that. And then you go about placing your sutures through the TFCC. We have tried different types of sutures, right from absorbable 2-OPDS to Ethibond, and now we favor fiber wire sutures, provided that the quality of the TFCC is robust. If not, the wire sutures will cheat out through the TFCC and render your repair ineffective. So we'd like to place a horizontal mattress suture, and then you can tighten the suture so as to restore the tension in the TFCC. And we do that while reducing the tension, the traction by about 2 pounds, and that would complete your peripheral tear of peripheral repair. Now I'm again doing the suction test, and you can see the TFCC doesn't get sucked into the suction tip as was shown earlier. So this kind of demonstrates how you would do a peripheral tear repair. What about avulsions of the TFCC from the fovea? And to repair this, we do either a transosseous repair or a arthroscopy assisted foveal reattachment of the TFCC. And this is pretty akin to your cuff repair. So if this were to be the head of the humerus and this were to be the cuff, you would put in your suture anchors here and then repair the TFCC back to the fovea. And to that end, there are very nice small suture anchors that are available. This particular view is underneath the TFCC. So let me just go back one slide again. So if you were to imagine that this is the bursal surface when you use the analogy of the rotator cuff, and if this were to be the articular surface, you are now viewing underneath the TFCC, and then your suture anchor will come in after you have debrided this particular area of false scar tissue. So going back to this slide again, that is the area where I would like to place my suture anchor, and then once you have the suture anchor in place, you then pull on the suture limbs, and these are woven through the TFCC in a manner so as to get the TFCC back on to the base of the styloid or the foveal footprint. The other indications that we very frequently encounter in quotidian practice are injuries to the scapholunate ligament, and we have published quite a bit on this particular repair. We call it as the arthroscopic dorsal capsuloligamentus repair, and this particular cartoon video will help you understand how we do it. So we use a standard wrist arthroscopy setup. Of course, we begin with primary viewing portal 3-4, but then you switch the portal. Now you are viewing through the 6R portal and working through the 3-4 portal, where you identify the limbs of the scapholunate ligament on the scaphoid and the lunate remnants. And then you switch to the mid-carpal portal. This is the 6U portal, whereas this is the the MCU portal and the MCR portal, sorry. And then you repair the ligaments in such a manner that you appose the capsule back onto the scapholunate ligament. So just to give you an arthroscopic view as to how we do it, this is now a mid-carpal view of the wrist joint. I am viewing through the ulnar mid-carpal portal. We identify the scapholunate ligament tear. My hook probe is coming through the radial mid-carpal portal. You can see that the dorsal capsule is completely detached from the scapholunate. You can see a ballotment of the scapholunate ligament, and this is just between the dorsal capsule and the scaphoid, which is on the other side in the lunate. And then once you have debrided and shaved and oops, just give me one brief moment to, yeah. And then you bring in your sutures and you get the scaphoid and the lunate remnant of the scapholunate ligament through the dorsal capsule. You retrieve the suture limbs, you tie your surgeon's knot or your Nicky's knot outside, and once you pull on the suture limbs, your knot will come and sit inside the mid-carpal joint, and you have what we call as a capsular ligament repair. And as you tighten the sutures and tie the other knot, the scapholunate articulation will come together. And this is just a post-operative clinical outcome at around 6 months with full range of movement and comparable grip strength on both sides. So as you can see from the t-shirt, this guy is a biker, a fellow biker for that matter, and then he's back to riding again. What about arthroscopy assisted reduction and fixation? So this was something that was described and propagated by Paco del Pinel from Spain, from Santander, Spain. Now he's in Madrid, and he has done a lot of pioneering work. So I personally prefer to reserve this indication for central die punch fractures. And if I were to give you an analogy, maybe of the Schatzkers, that will perhaps help you understand. So in the central die punch fractures, if you look at the radius in the lateral profile, when you have the volar and the dorsal cortices intact, and it is a central fragment that is depressed, arthroscopy helps you so you can visualize arthroscopically, make a small cortical window, and then elevate this fragment and accomplish a good reduction. However, this can also be used for different intra-articular fracture extensions, where you can do a provisional plate fixation, reduce the intra-articular fragments, and again do a definitive fixation. Another common indication that has been described is that for scaphoid fractures, either fresh fractures or even for fibrous non-unions or established non-unions. This is a mid-carpal view. This is the capitate. This is the proximal pole of the scaphoid. This is the distal. So this is the waist here, and you can see the fracture fragments being debrided. And then as you put in your screw, you can see the compression very, very clearly. So you can see the gap here, and once the screw is tightened, so this is arthroscopy assisted percutaneous fixation of the scaphoid fractures. Another added advantage of this particular procedure is to verify the screw length, whether it is projecting into the joint or not, and that will prevent any untoward outcomes for your patient. Just like we saw for the ankle, where the Herbert screw was proud in the ankle joint and causes abrasions of the articular cartilage. Another indication is arthroscopic bone grafting for scaphoid non-union. Here is a case in point. You can see a cystic non-union of the waist of the scaphoid. The CT scan showing this in greater clarity. And these are good indications for minimally invasive fixations and arthroscopy assisted. Oops, this is not advancing. Okay. Just give me a moment, please. This seems to have hung upon me now. Yeah. So otherwise, you would do this in an open manner with big incision, harvesting a big tricortical iliac crest bone graft. What if we were to do this in a minimally invasive manner? So the steps are pretty standard. You first identify the fracture non-union site. You would debride it with curettes and shavers and burrs, and then we like to pack it in with mosylized cancellous bone graft. And once you have done that, you would then fix it percutaneously with a Herbert screw. So again, these are different views of the bone graft being impacted in place. Care has to be taken to avoid spillage of the graft into the joint space. So this is just a little bit of a caveat, and then we use these McDonald's retractors to impact the bone graft in place and prevent any spillage into the joint space. So that is one indication, and with that behind us, we then come to the slack wrists, or the snack wrists, where you have these osteophytes and arthritic changes. You can do styloidectomies using arthroscopy assisted procedures. You can take a look at the ligaments, the cartilage, and that would kind of give you the opportunity to deal with this in a minimally invasive manner. Another indication is where you have radio-ulnar impaction due to ulnar positive variants, and we call this as the arthroscopic Felden procedure. More often than not, there will be a central perforation of the TFCC, and you can use that to your advantage by doing a resection of the head of the ulna through this perforation. So you cannot repair this because this is an avascular part, pretty much like the meniscus in the knee, and then you go through that central perforation and you can do a resection of the distal ulna so as to resolve the conflict. So this is a schematic diagram on the left with an arthroscopic view on the right as to how we remove the head of the ulna, taking care to preserve the articular cartilage in the sigmoid notch. So you have to be very careful to remove only the head of the ulna that is proud and is abutting against the lunate, and prevent any damage to the sigmoid notch cartilage so as to prevent any arthritic changes and problems with chronosupination because of the procedure. So here is a clinical picture of and an X-ray. You can see that we verify the pronation and supination at the end of the procedure. You can see the ulna rotating in the sigmoid notch, the head of the ulna being resected. So here is the ulnocarpal abutment, and here you can see that the ulna has been resected so as to resolve this conflict between the ulna and the lunate. Another good indication for people who want to embark on their journey of wrist arthroscopy is to start with ganglion resections. So this gives you the opportunity to look into a joint that is otherwise pristine, but there is a ganglion that can be resected. Again, please bear in mind that about 90 to 95% of ganglion cysts do not require surgery. It's only when people have failed a fair trial of non-operative treatment you would counsel them for surgery. In our books, more often than not, a ganglion cyst that is a result of an underlying scapholunate ligament injury qualifies for an arthroscopic resection that gives us the opportunity to not only remove the ganglion cyst but also do an arthroscopic repair of the scapholunate ligament. Whenever you resect the ganglion, you make sure after you remove the stalk to create a window of 1 millimeter by 1 millimeter so as to prevent any recurrence of the ganglion cyst. So you can start seeing the extensor tendons through this arthroscopic view. It is extremely important to not damage the dorsal intercarpal ligament by a very enthusiastic and over resection of this particular window. Otherwise you will cause an instability of the wrist joint. We have also described insertion of pyrocarbon implants for proximal pole non-unions, as well as the distal pole of the scaphoid, and also for scaphotrapezial arthritis. And this is something which is also an indication for arthroscopic insertion of these implants. So this is just a spacer that will fit into the resected aspect of the scapholunate of the proximal scaphoid and allow for painless wrist movement. So whenever a patient qualifies for a salvage procedure rather than a reconstructive procedure, such as a vascularized bone graft, this is something that can be used for dealing with these patients. Another indication that has recently been acknowledged is arthroscopy-assisted partial wrist fusion. And basically, partial wrist fusion is something that is performed when there are arthritic changes that are limited or restricted to a particular compartment of the wrist joint. For example, a SNAC 1, 2, or 3 kind of a wrist. And this is basically achieved arthroscopically to maximize motion and to enhance union by preserving the biology. And arthroscopy allows for excellent visualization. This need not be belabored too much, and this is something that more and more people are performing these days. A standard wrist fusion would be performed through a big incision, such as is being shown in this particular slide, and then you debride the cartilage and then you fuse using plates or screws. What if we could do the same thing in a minimally invasive manner? So pretty much like ankle fusion, here we are performing a partial wrist fusion for a Kienbock disease. We do an arthroscopic resection of the lunate through the radiocarpal joint, and then you move on to the midcarpal joint, and then you remove. So this is the scaphoid, and this is the scaphoid, and this is the capitate here, and you're removing the articular cartilage on the opposing surfaces, and then you can do a percutaneous fixation. This is a capitolunate fixation that you can see for a scaphoid non-union, arthroscopic resection, and capitolunate fusion. So some other indications that have been described in literature are already, I've talked about the scaphotrapezial implant, CMC replacement. We do a tendon interposition for Eaton-Littler stage 2 and 3. A cervic-apondgy procedure also can be performed. You can do interposition arthroplasty for slack wrists, partial wrist fusions. We talked about synovectomies and rheumatoid and tuberculosis. You can do arthroscopic arthrolysis for stiff wrists. Carpal boss resection also can be performed arthroscopically. We have already talked about TFCC. Grafting has also been talked about. What is of interest is perhaps extending the indications for cartilage defects, but that's still out in the open. And then, of course, very rarely you do have some foreign bodies or loose bodies that could be removed with an arthroscopic assisted kind of technique. Another indication, very briefly, is carpometacarpal joint arthroscopy. Here, the position is a little different in the sense that we use traction only to the thumb, and then you use the portals between the ulnar CMC portal is the first visualization portal, which lies exactly between the V that is formed between the first and the second metacarpals. And very carefully you dissect, you have to protect the sensory nerves out here. And then you use a very small 1.9 scope rather than a 2.7 mm scope to get into the joint. And once you have done that, you can do shrinkage procedures for laxity. So this is the oblique ligament, the volar oblique ligament that can be shrunk, and that kind of gives you pain relief and shrinkage. You can do shaving, and you can treat grade 1 and grade 2 arthritis with these procedures. So this is a rasp that is being brought into view here, and kind of that helps you with hemiresection arthroplasty for CMC arthritis. and that creates a nice joint space. And then you can use some interposition material such as a tendon, anchovy. People in the West are using a graft called an Artelon jacket, which is not available here, and that gives you a very good opportunity to deal with this problems. So what is the future, perhaps description of new lesions like the one we have done, the dorsal ligamentous septum, and we also have something else, a park lesion that has been described by one of my mentors. And then also maybe use the use of robotics and flexible scopes such as that in gastroenterology being available for wrist arthroscopy that will give us better access to corners. So to conclude, wrist arthroscopy has certainly established itself as a routine procedure in the armamentarium of the upper limb surgeon. It is an adjunct to diagnosis, but it does have an established therapeutic value, and the indications are ever expanding. So with that, I would like to thank you for the attention and the opportunity to speak here at this webinar. Thank you very much.
Thank you, sir. Thank you for excellent presentation. It was
Thank
a privilege and honor to have you with us. Mehta Sahib, do we have any questions or time left for discussions?
I think we are running late, and it was a fantastic presentation by both speakers. Dr. Milind sir had a great work with the ankle, and now it's followed by Dr. Abhijeet, and they're fantastic view. So I think all the young guns will be now pushing for learning all the SCOPYs beyond knees and shoulders. Great, thanks, kudos.
Yeah. Before we proceed for the hip arthroscopy, the Sun Pharma medical representatives want to showcase Mr. Kshitij, Mr. Chirag, if you are there. You want to talk about some of your medicines?
Yes, sir. I am Veerbhadra Singh Goyal, working as a RSM, looking after this cross-line life entire Gujarat region. So it's always privilege to talk or have a thanking words to such kind of events. As you know, Dr. Sun Pharma is always believed to provide such kind of academic in such kind of in future also. Sun Pharma is ready to provide such kind of platform, right? So request Doctor, do support us, do support cross-line life products such as Nista, Ultra and Histosine. With this, I am ending my talk. Thank you and have a good night. Thank you very much.
Yeah. Thank you, Mr. Goyal.
Thank you.
Now we proceed with the talk on hip arthroscopy by Dr. Prathmesh Jain, sir. Sir, please proceed.
Yeah.
Hello.
Yes, sir. We are able to. Yeah, a bit louder, sir.
And can you see my
We
presentation?
are able. Yes.
Can you
we
see
are
my
able to see
presentation?
also. Yes, sir.
Okay. So, so hip arthroscopy is basically a very new hip arthroscopy is basically a very new cup in the basket basically. So basic requirements, if I talk about, I would like to focus this talk for the newcomers and those who want to start hip arthroscopy. The basic thing that is required is the surgeon should have a good knowledge of surgical anatomy of the hip. He should have a good knowledge of shoulder arthroscopy. As far as the OT requirements are concerned, you should have a traction table along with the CR. You should need specific instruments, and you should believe in the concept of hip arthroscopy and FAI. And there is a learning curve attached to it. So, but if you keep persistent, you will do good. Now, if I talk about the indications, the predominant indications are femoroacetabular impingement, the synovial pathologies, ligamentum teres issues, loose bodies, and snapping hip syndrome. Now, FAI, what is FAI? FAI is basically a femoroacetabular impingement, and this is a pre-arthritic disorder. So it is basically a disorder which leads to arthritis in future. And there are two types of FAI, a pincer type and a cam type. The pincer type is on the acetabulum, The cam side is on the femur, and you may have a combined sort of a combined sort of a FAI, which includes both pincer and cam component. So this is the lateral view, and you can see that there is a overgrowth on the anterolateral aspect of the head, which is called as a cam lesion. And then you can have a pincer lesion, and then you can have a mixed kind of a lesion. The prevalence of FAI is about 10 to 15% as per the Western data, but it is less in India. But it has a higher incidence in athletes, martial art players, and kickers. Now this is which is called as a center edge angle, and this is the coverage. So both of these things are increased in cases of femoral acetabular impingement. Now here we can see that there are cartilage lesions and labral tears on the anterolateral aspect. So the anterolateral aspect is the key zone where there is the problem in the cases of FAI. Now this, you can see that there is a cam lesion, and what you do is called as an osteoplasty. You resect the cam lesion, and then you do a labral repair in the end. Now I will be talking about more of an Indian perspective, because most of the studies and most of the work that you will see will be coming from the West. But in India, in my experience, the synovial pathologies are more common than FAI. And in Indian patients, an acute tuberculosis is a common indication. It is a good indication. So many patients of stage 1 or stage 2 tuberculosis in active disease is, I think, a very good indication for a hip arthroscopy. Now the required infrastructure that you will need is a traction table. You need a wide central post. You need a 70-degree scope with a long working length, and you will need a cannulated trocar and cannula. You need a half pipe and a beaver blade. Beaver blade is nothing but a knife, which is a capsulotomy knife. Now you can do this hip arthroscopy in either a supine position or a lateral position. The more common position that we use is a supine position. The reason is because it is an easy setup. We have a orientation because we are doing trauma surgeries like DHS in the same position. The only problem is it is a little bit difficult in some obese patients. The lateral position has an advantage in obese patients. Otherwise, the setup and everything is difficult in the lateral position. Now, coming on to very basic portals. So the more common portals are the anterolateral portal, which is the initial portal, starting portal. And then you can have two more portals, that is the anterior portal and the posterolateral portal. Now the portals have to be made under C-arm guidance initially if you want to approach the central compartment. Now you have to be very careful about the lateral femoral cutaneous nerves, femoral artery nerves, and sciatic nerves. So these are the three things, neurovascular structure, that you need to be very careful. The very important maneuver here which is required is called as an interportal capsulotomy. And when you make your anterolateral portal and the anterior portal, you have to do a capsulotomy in between those two portals, because that will give you a good space to work. Because the most important problem that we all face in hip arthroscopy is basically it's a very tight joint, and the doing SCOPY is not that easy. So there are three components of hip arthroscopy: the central compartment, peripheral compartment, and the peritrochanteric compartment. Now this is very important. If you are doing hip arthroscopy, just like tourniquet time, you have to have a traction time concept. So at a stretch, you should not have a traction more than an hour, and total duration of your traction should not be more than 2 hours. And if you extend that, you can land up into complications. Now, peripheral compartment first SCOPY, this is a concept developed by Dr. Thomas Bird, and it is for tight central compartments where the initial passage of the scope into the central compartment is difficult. So in this procedure, we go to the peripheral compartment first, and then we do our capsulotomy, and then we go to the central compartment. So it is very useful for a tight compartment. Now, coming to the central and the peripheral arthroscopy. The central arthroscopy, we do it in a traction position, and it is very good for intra-articular pathologies. You can do pincer procedures, and you can address loose bodies and chondral lesions by this. The peripheral compartment is an extra-articular compartment. It is an intracapsular approach. you can resect the CAMS procedures and you can resect the synovial pathologies by this procedure. Now, this is the greater trochanteric pain syndrome. This is a very common. This is called as external snapping hip syndrome. This is very common in our practice, and this can be very nicely and very easily addressed with the hip arthroscopic surgery. Now, peritrochanteric arthroscopy, as I told you, for external snapping hip syndrome, which is also called as coxa saltans, this is a very good procedure. You may have heard, you may have seen a lot of patients with a snapping hip syndrome, the external snapping hip syndrome. So peritrochanteric arthroscopy is very good because you can approach the subgluteus maximus bursa and you can address the ITB which is tight. You can do a little tenotomy of the ITB band and that will release the symptoms of the external snapping hip. Then synovial chondromatosis is a very good indication. So in these kind of conditions, you can do an arthroscopy and do removal of loose bodies. PVNS is very good indication. So if you have small synovial overgrowth, you can remove it with the arthroscopy. Now I am presenting some very interesting cases. Now this is the first case. She's a 35-year-old female. She presented with a limp and pain while walking along with a groin pain. And on examination, the internal rotation of hip is painful. And this was her X-ray. And you can see that there is a very prominent calcification at the pincer side. So you have a very, very prominent calcification which is seen. Otherwise, the hip is normal. She's a young lady and she is painful. So we did the CT scan and we can see that there is not a classical pincer lesion on the CT, but it is actually an aberrant calcium deposition which is seen in the paralabral sulcus area. So we started with the hip arthroscopy under C-arm and we do the procedure under C-arm on the traction table with a wide perineal post, and we inserted the first needle, and over that we inserted a nitinol rod, and then we made all our portals. The upper portal is the anterolateral portal, the lower one is the anterior portal, and this is a small video. So this will give you an idea about what all we do. So here we are doing a portal. So this is a small needle and we put a nitinol wire through the needle. And once we put the nitinol wire, this is a freehand. This is the anterior portal and this is a freehand approach. So you put the nitinol. Can you see the video? So can you see the video?
Yes, sir.
Yes, sir. We can see this video.
So this is a anterior portal. So the first portal is the anterolateral portal, and then we will make an anterior portal. And after that, we will do a capsulotomy to increase the exposure. And the needle should pass just beneath the labrum. Okay. And you can see a yellowish discoloration there above on the top of the labrum. Can you appreciate that?
Yes.
So this yellowish discoloration is a sign or is a marker of the pathological area. So here we can see that the cartilage is normal, the labrum is normal. What we do here is we do a capsulotomy. You can see there is a little bit of synovial hypertrophy. You can see a synovial inflammation, the reddish discoloration out there. Okay, and you will do a little bit of capsulotomy over there. And then we will approach the area which is close to the paralabral sulcus. So these are our cannulated instruments which we have inserted. And then you can see that the calcification is seen into the picture. Can you see? Once we remove the capsule, you can see the capsule, the calcification right there.
Yes, sir.
Can you appreciate that? And we have just removed removed the capsule. And this is the labrum on the top and the femoral head is on the bottom. And with the RF, we are releasing the capsule. And here you can see the amorphous deposits of calcium which are coming out. Okay. So this is like the calcific tendinitis of the shoulder. If you have any one of you has done SCOPY for the calcific tendinitis of the shoulder, this problem is akin to a calcific tendinitis of the shoulder, and you can see that there is a lot of calcium which we have, which are washing out and we are removing. We will do it with the RF and the shaver sequentially. And the pathology of this problem was actually a labral tear, which has actually led to deposits of the calcium in the paralabral sulcus. So once we remove all the calcium, then we will do a procedure which is called as a labral repair, which is similar to a labral repair that we do in a Bankart lesion or a shoulder. So once we remove all the calcification here, then we will be addressing the labral tear. And the labral tear is best addressed with in hip arthroscopy specifically, I would like to use a knotless kind of a suture, because we want to place the suture away from the articular margin, because a very common complication here in hip arthroscopy, because it is a very circular kind of a joint. Now here we are using the probe to remove the calcium deposits. And this, as I told you, is just on the posterior aspect of the labrum. So we are probing the posterior aspect of the labrum and removing all the calcium deposits out from there. Okay, and here we are using the shaver for the same purpose. And then in the end, what we will do is, as I told you, we will pass a suture there on the labrum, and then we will use a knotless anchor to repair the labrum. So this is the suture that we pass through the labrum, and this is a penetrating suture device, and we pass it and we do a lasso loop technique. We pass the fiber wire over itself, and then we use a knotless suture to do a final repair of the labrum. And this is the lasso loop technique, and this has holded the labrum nicely. And then on the superior aspect, I use a knotless anchor to bury the anchor down. So finally, we have done a nice labral repair to prevent the recurrence of this kind of a lesion. So these are the operative steps. These are the cannula and the needle in the post. This is the push lock anchor that we have used to repair the labrum. And this is the trajectory of the anchor. You can see that the anchor is in the bone. So the anchor should not go into the joint. So problem with using a knotted anchor is you are close to the articular cartilage, and you may penetrate the joint in the hip joint in particular. So it is better to use a knotless anchor here. And these are the follow-up pictures of the same patient after 6 months with full range of motion and absolutely no recurrence of the calcification. Now, the second case, he is an 18-year-old young boy. He presented with pain in the groin, difficulty in walking and limb. And I would like to acknowledge Dr. Ramesh Panchal sir, because this patient was referred from Baroda, from Ramesh Panchal sir. So this was actually the case, and you can see that there is a large bump in this 18-year-old patient. There is a large bump. You can see a large kind of a kind of a large bump which is seen here. And on the CT scans also, you can see that there is a large bump there. And there was a predominantly cam lesion, but a small pincer, and the labral tear was also there. So we addressed everything. We resected the cam lesion predominantly. We did a labral repair along with a rim trimming. And these are the post-op pictures. You can see that there is these are the post-op CT scans, and you can see that the cam is resected nicely here. And this is a post-op CT scan in the 3D view. You can see that the whole of the cam lesion is resected. And this is a post-operative picture. So almost a full range of motion after 6 months. He has a good internal rotation and external rotation, which was not seen earlier. Now, another case, he's a 40-year-old male patient. He has pain in the groin with catching and locking sensation, pain on particular fraction on the internal rotation. and you can see that there is a large synovial region on the anterior aspect. So this lesion is in the peripheral compartment. This is not in the central compartment. So we did a peripheral arthroscopy and we removed this lesion. So these are the intraoperative pictures, and this is the lesion that we removed from the peripheral compartment. So on biopsy, this turned out to be a PVNS, and these were the final pictures. The last case, this is a post hip dislocation. The patient had a hip dislocation which was closely reduced. But on serial X-rays post-op, it was an eccentric reduction, and there was a small loose body inside the joint. And this small loose body was removed with a hip arthroscopy, and the patient had a very uneventful recovery. Now, thank you. And in the end, I would like to say that I will be very happy to help any surgeon personally if anyone wants to start hip arthroscopy, because it is, I know it's a difficult journey. It's a difficult way to go, and it has got a long learning curve. So anybody who is interested to start a hip arthroscopy, I'll be very happy to help him personally. Thank you.
Thank you very much, sir. It was excellent presentation and so kind of you that you are going to help us to start the hip arthroscopy. Now the panel is open for discussion. The delegates, the participants, if they have any questions. Sir, I would like to personally ask one question. What is your post-operative rehabilitation protocol for different patients of hip arthroscopy?
So, like I told you, the most common indications that I do hip arthroscopy is a synovial pathology. So if the patient has got a synovial pathology like a tuberculosis, like a PVNS, or a synovial chondromatosis, there is no role of any restricted protocol. You can start the patient non-weight bearing as weight bearing as tolerated. So from the second day, you can start weight bearing as tolerated, as permitted as far as the pain is concerned. If you are doing any kind of a bony procedure like a cam resection, specifically if you are doing a significant osteoplasty and removal of the cam region, it may cause a little bit of weakness in the neck area. So in those patients, I would like to keep the patient non-weight bearing for a period of 3 to 4 weeks. And if you are doing a labral repair, again, I keep them non-weight bearing for about 2 to 3 weeks, and then we can start with partial weight bearing and full weight bearing after 1 month.
Yes, sir. And there was one question from Dr. Alpesh Parekh Sahib for Dr. Abhijeet Wahegaonkar. Sir, Dr. Abhijeet, you are still there?
I think he left.
Okay.
I think he has
Mehta
left.
Sahib, you want to ask?
Yeah. This question is for Dr. Prathmesh Jain.
Yes, sir.
As we know that FAI is something which are recognized nowadays very commonly. So how do you decide whether to go for a non-surgical or surgical treatment for this FAI patient?
Yes, sir. So it's a really difficult judgment. I go with both the clinical findings as well as the MRI. So clinical findings of groin pain, catching and locking sensation are a guidance. If the patient is painful and symptomatic, like this young boy who has developed this FAI at a very young age of 18 or 19 years, these are very classical indications. Now, if the patient is middle-aged, so if the patient is like say 40 and 50, and the patient is not much symptomatic, then you go on for a conservative management. But if the patient is symptomatic and the younger the patient, there is more indications for surgical intervention.
So do you rely upon the X-rays or MRI and X-ray both?
I personally, there are a number of techniques in X-ray in which you can see it, but in my personal experience, I have seen that in our Indian scenarios, the X-ray quality is usually not that good, and MRI is readily available. So before doing any procedure or diagnosing and advising surgery for FAI, I always get an MRI done in our practice.
But for the measurements, for measuring the pincer and cam,
I'll go for the MRI, and occasionally, like in this particular case, the case number 2 that I showed, I get a 3D CT scan. So that will give you a better 3D kind of a picture from where you need to do a resections and everything.
And have you found any patient who's come with a sacroiliac problem which was related to the FAI?
Usually, sir, sacroiliac problems will give a pain in the back of the hip. and these patients will have more classical anterior hip pain. So our patients for hip arthroscopy will be classical patients in which there will be either an anterior hip pain, and in which you will see a FA kind of a picture or a synovial pathology, or a lateral hip pain, which will be a gluteus maximus bursitis or like a snapping hip syndromes. So more of an
No,
anterior and lateral hip pains we are concerned when we are discussing
I
about
understand, but a
hip
sacroiliac
pathology.
presentation is one of the features which is probably secondary to the FAIs. So,
It may be, sir. In my practice, I have not seen a sacroiliac pain which is FAI.
okay. And a question for Dr. Abhijeet, sir. About the
Yes, sir.
TFCC injury, which, yes, Dr. Abhijeet, TFCC
Yes,
injuries
sir.
which are very frequently suspected in our clinical practice. So, what would be your advice? How to go about this suspected TFCC? Because we may not get a good MRI. So, how to decide
Right.
about the treatment?
Sure. So, first and foremost, I think we need to recognize that TFCC is just one of the many causes of unnecessary wrist pain. And there is no substitute for a detailed history taking and a thorough clinical examination. More so because unnecessary wrist pain has a litany of etiologies, or there are so many different reasons why a person will have unnecessary wrist pain. So if you've negated all of the causes and then you think that TFCC is the reason why this particular person has unnecessary wrist pain, then you need to take into account several different scenarios. First and foremost is the chronicity of the problem, whether it is an acute or a subacute or a chronic presentation. What are the symptoms of the patient? Are the symptoms exaggerated or kind of aggravated by provocative tests and strenuous activities? So basically, I like to look at this particular problem as pain alone or pain which is associated with instability. Now, if there is pain alone, we begin with non-operative treatment such as splinting and physiotherapy and modification of activities and gradual. And we tell the patient, we warn the patient that this may take anywhere between 3 to 6 months. You cannot put a splint for 3 weeks and cannot expect the patient to be fine after 3 weeks. So please advise the patient accordingly. Now, if there is pain with instability, I completely concede that we do need clinical investigations. But again, I always tell my residents and fellows that your MRIs and your X-rays and your CT scans should not be a eureka moment. They are only meant to supplement and confirm what you already know from your clinical examination. And a lot of times we have false negatives. So say, for example, there's a chronic TFCC tear, there's a frank instability, provocative tests are positive, and the MRI still may be negative. There are multiple reasons why. One is what Tesla MRI you're getting, what is the thickness of the slice, and of course, the expertise of the radiologist. So I think one of the best way to bridge that gap is to call up the radiologist, talk to the radiologist and tell them what you are suspecting clinically, and please take a look at that particular area. Otherwise, it just becomes a routine screening and then they're just looking at images. So talk to the radiologist. And then if there is instability, more often than not, they require surgery at some point or the other. So I was just discussing this with Dr. Alpesh through the chat. I believe that then in these cases, the gold standard for diagnosis as well as therapeutic intervention is arthroscopy. And depending upon where the lesion is, whether it is a 1A, 1B, 1C, 1D, or a chronic tear, you would then plan the treatment. So it is not just one particular point. You have to take into consideration all these different scenarios and then deal with the patient appropriately. I hope that answers the question.
Thank you. Yeah. So that is what I wanted to hear. So all the young surgeons who are now banking upon starting with this other joint, rather than concentrating upon just learning the technique, they should be going into the details about the joint, learning the anatomy, and all this conservative and non-conservative aspect, rather than directly delving into the surgery first.
Right,
Thanks for making it clear. Yeah.
absolutely. Thank you, sir.
Any more questions? I think if we don't have any questions, we can get to the vote of thanks by Dr. Alpesh Parekh, sir.
Am I audible?
Yes, sir.
Hello, everybody. And today I think it was a wonderful session, and it was a sort of a bridging of the two ends. As far as we know, we are quite familiar with only two scopies, that is a hip and shoulder, or a shoulder and knee joint. But today, because of all our learned people along on this platform, we are able to connect all the dots regarding the SCOPY, and I think the horizon of SCOPY is also increasing. And what time before was considered quite invasive has gradually come to MIPO, and MIPO has reduced down to SCOPY. So the future appears bright, and I am very much thankful to all the speakers, especially Dr. Milind sir, Dr. Abhijeet sir, and Dr. Prathmesh Bhai for highlighting all the minor points and all the relevant anatomy, and also focusing how to take care of each and minor things which were neglected some few years back. I'm also thankful to Manoj Bhai for being a helpful and panelist to this session. Also thankful to moderator Aditya and our own Baroda Orthopedic Association committee members, Dr. Pranav and Dr. Smit for being with us. I hope we can conclude the session. Thank you very much. And I am extremely sorry for the inconvenience that was initially with the technology platform. But I think we need to take care and look into this so that things do not repeat again. Thank you.
Thank you. Thank
Thank
you
you so
very
much.
Thank you,
much.
sir. Thank you.
Thank you, sir.
Thank
Thank
you.
you.
Thank you. Bye bye.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you, everybody.
Stay
Sir,
safe, everybody.
thank you. Thank you, sir.
Thank you very much, sir. Thank you for accepting the invite, sir. Thank you.
Thank you, sir.
Thank you. Bye bye. Bye.
Bye, Pranav.
Yes, sir.
Thank you, sir. Thank you.
Bye. Bye.
Thank you. Bye.